Welcome to the 508th episode of the Jami Dulaney Plant-Based Wellness Podcast. My name is Jami Dulaney, and I'm your host. I'm a plant-based cardiologist and endurance athlete living in Southwest Florida. Thanks for listening. I haven't given you much of an update on my running lately, I guess, but we're going to do a 50K in Florida next weekend. Apparently there's a nice little section of sugar sand, which is like that white fluffy sand that's great on the beach, but not so great to run on. But then there's actually a little few hills for Florida. I think the whole course has 697 feet of elevation, but if you think that currently I'm at about 13 feet of elevation, it's a little bit of a hill. Nevertheless, it'll be good practice. 50K now, 50K into April, and then it's Cruel Jewel in May. I've been working with a running coach as well, and he has been giving me speed workouts and to change things up a little bit. I'm getting some speed back in my legs, despite somewhat dreading them. The first week I really dreaded it. The second week I kind of had a mindful turnaround, looking at there's no reason why I can't do this and hold on, and it's really good practice for Leadville. So it's a lot of good opportunities to do some image work, as well as hang on and breathe tough, because I'm going to be breathing hard when I get to altitude this summer. So all good. Continue with the strength workouts from Nathan. So I got quite a coaching staff. My mindset coach and my actual running coach and my strength coach. So hopefully these people, I guess if I comply, can get me up and over some of these races coming up. Ankle's doing pretty good. Don't have any discomfort at all while I'm doing my speed work. Maybe a little bit of tenderness afterwards, but not much really. For the most part, I have forgotten about it. So that is all good. I rarely have to go to the hospital with my patients anymore, but there are a few people that have slip and falls, and I have some people that have some illnesses that they're working through. And one particular lady who has been doing quite well with lung cancer, and she had, though, some, you might say, complications of treatment with some esophageal problems and gastritis, but ended up having a pneumonia. And she had to go to the emergency room and ultimately get admitted. And this is not atypical for any emergency room anywhere in Florida or any place else. I've seen people online talk about similar hospital situations. But the hospitals are markedly overcrowded, especially the emergency rooms, with the advent of electronic medical records and all the clicks that it takes to get someone discharged, and communication is gone because most people communicate through the computer as opposed to talking to nurses directly, and nothing is taken verbally and nothing is written down. So getting a patient admitted and getting a patient discharged is very time consuming. It's one of the reasons that lead hospitals to be very much overcrowded. But the other thing, a lot of people come to the emergency room as their primary care source that shouldn't really be at the emergency room. Don't have a doctor that can see them because the doctors are too busy in their office seeing healthy people to actually get people in for an appointment. So when they have an illness that could be treated as an outpatient, often times they ended up in an emergency room. So I would strongly suggest that you think highly and long before you go to the emergency room. If you're stable, meaning you think your blood pressure and your heart rate and your breathing are stable, that's good. You're going to be good. Don't go to the emergency room. If a bone's not sticking out and you can wait to see a primary care orthopedic guy the next day, then I would wait and not go in for a potential, limb fracture, unless it was a upper leg fracture, because people can lose a lot of blood. Dislocations most likely have to be seen in the emergency room. And again, this is just my perception, not necessarily direct medical advice. But if you're not actively bleeding, then things should be able to be taken care of as an outpatient. Most infections should be able to be treated as an outpatient, especially if caught early. We never had an admission for COVID, and all the time COVID was rampant because we saw people quickly, treated them as an outpatient aggressively with a regimen that didn't include toxic drugs, and they did well. So, if you're looking for a doc, make sure you can communicate with them. People have my number to call if they have an issue, and sometimes they say go to the emergency room because sometimes you have to go to the emergency room. But if you can avoid it, you should avoid it because the care, you just kind of get lost in the system pretty good. In this particular case, the patient was admitted, but the admitting staff is upstairs, the patient's downstairs. Nursing is sort of guided towards emergency visits downstairs as opposed to upstairs, and patient didn't get out of bed, patient didn't get bathed, patient didn't have anybody checking on her, glasses, various things on the floor. It's just not good care. So if you go to the hospital, somebody that you love goes to the hospital, you got to stay with them. You have to have an advocate with you, because if you don't have a patient advocate, somebody that can go outside, call somebody, it can be a lot of trouble and even dangerous. Luckily, my patient is doing well. Thanks for asking. And hopefully she'll be out soon. So my therapy for this patient as her primary care was to bring her nutrition, because she got left, even though she's markedly underweight, she got left without nutrition. So I brought her a chia, hemp, soy milk, banana pudding, again, to try to get some nutrition. She was on soft type material. And again, consult with your doctor if you have a primary care. If somebody's in the hospital, can you bring them food? Don't rely on the terrible hospital food. I also brought her hand warmers because her oxygen saturation was being measured by a pulse ox sticker on her finger, and her fingers was freezing in the emergency room because, the blankets are like little sheets. So she's freezing cold, and her oxygenation is not good, but you can't rely on it because her hand's so cold to pick it up. So I actually brought her hand warmers. So consider doing that for your loved ones. Again, got to take matters into your own hands sometimes. A long time ago, I had a guest on my podcast, Victoria Sweet. Probably should look her up again. She wrote a book on slow medicine and In God's Hotel, which was about a almshouse that basically used common sense to treat patients. Things like, again, keeping them clean, preventing secondary infections by changing the bed linens, preventing skin breakdown by turning patients, and preventing pressure sores. Good attention to nutrition. Not just whatever people can get. And if you're a plant-based and you go to the hospital, it is really sad most of the time. Even though I've worked with this particular hospital to get a menu, when things get complicated like thickened purees, nobody thinks outside the box to add protein powders, and that was also in my chia pudding that I brought her. Chia seeds, flaxseed, people don't think about omega-3s, but omega-3s are very good as anti-inflammatories. There are many practices that go on in a hospital that don't have a lot of sound advice or certainly common sense behind them. And you may have experienced it, but especially with COVID, but anytime there's a patient that may have some sort of infection, especially if it's a highly resistant infection, there's strict isolation, and the patient visitors have to have the plastic gowns that look like people that are doing butchering that you put over your head, and it covers your arms, but it doesn't cover your back, so your back is exposed. Gloves and a mask. Most people that aren't in the medical field, and probably a lot that are in the medical field, have no idea how to get these things on without being contaminated. And even as a physician, there is no way that I can get one of these plastic gowns on and go see one patient, and come in and come out and not contaminate something. You have rubber gloves, you have the thing over your head, you have your own stethoscope. So you have to, re-glove to try to wash your stethoscope, drop it underneath the gown into your pocket, don't touch anything. And again, your back is not covered. So when people come in to visit, they sit with their backs against the chairs. You have to take these things off somehow. People, are touching their face, touching their mask. Just like masking in general is not effective because people don't know how to use them. We don't use masks in the operating room to prevent infection spread. We use masks in the operating room to keep our nose from running on the patient. And you put that mask on first, and by no means are you trying not to contaminate yourself because you're not in the OR when you put that mask on. Then you wash your hands, then you go put the gown on and do the procedure, and then and then you take things off in the reverse order, with the mask coming off when you leave. And you don't touch your face, so you don't touch anything once you're in a sterile environment. But if you've ever watched people with the mask, they're always adjusting it because the things ride up and they move. They cause your face to itch, they cause your nose to itch, and people are touching them, so they're contaminated from the get-go. And your hands are really what transmit infection. So washing your hands with good old-fashioned soap and water is the best thing you can actually do, and rubbing them together and drying them off with a paper towel. Forget the mask. The gowns don't work. Obviously, you can't not do them in the hospital, but you see people dragging their purse across them, sitting their purse on the... The only time a hospital is clean is the first day that it opens. And after that, the antibiotics and the cleaners and everything that's used select for the most potent bacteria known to man. And that's why when people come into the hospital, they often get infections that have to be treated with elephant gun-like antibiotics in order to try to clear them, which suppresses their immune and destroys their microbiome and causes even more problems. So that's why we try to keep people out of the hospital at all costs, again, unless necessary. So even though this masking, gowning procedure has no randomized controlled trial that says it decreases infections or decreases spread of infections, it keeps going. And it doesn't change, and people don't call it into question, never mind the plastic and the garbage and waste that's generated for changing these gowns. Of course, when cafeteria workers come up and the trays, and the contamination is just all over the place. If there was a light showing where all this would have been, it would make your head spin. But one thing that is starting to be questioned now that has never been questioned is the good old aspirin. Originally, it was one of our only pain medications, salicylic acid. Bayer came on board and did a beautiful job of marketing this medication for fevers early on, and then it was, again, it's contraindicated in children, but in my childhood, aspirin was given to children for fevers. And in general pain, people took it every 4 hours, people took it for headaches. And while it may reduce pain in some instances, it caused an awful lot of bleeding. But when it came to heart attacks and clot prevention, it was thought to be a good thing. And the way aspirin works is it works on your platelets to decrease the platelets from clumping together and forming a blood clot. And when you disable the platelets with aspirin, you more or less disable your platelets from clumping, a good many of them, not all of them, but a good many of them for the life of the platelet. So until you generate new platelets, those platelets don't stick together very well. They do some, but not entirely. So when somebody thinks they're having a heart attack, they're supposed to chew an aspirin. Think they're having a stroke, supposed to chew an aspirin. Given an aspirin in the emergency room. Told if you're over 50 to take an aspirin to prevent a heart attack. Certainly you're given an aspirin on the way out the door and while you're in the hospital, and even dinged as a physician if you don't order aspirin for your patients. It is so ingrained in the medical practice that Bayer even sends physicians boxes of aspirin so that we can give them away to our patients. And for many years, I would receive cases of aspirin into my office, and there's still cases of aspirin sitting in the back room that I do not distribute. But recently, people have started to question the studies that have led us to use aspirin and to have such protocols. And the reality of it is, when you look at a meta-analysis, which is a group of well-done studies, so you look at all the studies on aspirin and you pick out the ones that are the best done, and then the statistics on those are looked at and compared, it's still a wash. There are a few studies that show aspirin might be good. There's a few studies that show that aspirin might be bad. But there's certainly never been a study in women that show that aspirin does anything. Women were excluded in a lot of the studies. And now even the mechanism by which they work is starting to be questioned, that perhaps bleeding occurs first as a secondary side effect of aspirin that then causes ulceration and plaque and scarring and narrowing of arteries. So looking at a recent study published in the Journal of American Medical Association, looked at over 100 person years, largely men, and they can't even come to a conclusion that it decreases all-cause mortality. Primary prevention, again, if you haven't had a heart attack, no benefit whatsoever as far as cardiovascular events or mortality. If you look, there was a large study looking at orthopedic surgeries, 17,044 patients. They were given an aspirin, 160 milligrams daily, and there was actually an increase in myocardial infarctions. So, what do we do, again, after heart attacks, and the rules of the hospital and protocols and, boxes to be checked on electronic medical records and the legal aspect of things and peer pressure? How do we get things turned around and people to actually look at data? That's the big buzzword. Look at the science, look at the science. Well, the science on aspirin is universally flawed. Science on a lot of things, when we start to look at it, is universally flawed. The study is only as good as, what went into it. So while there might be some benefits in some people, there's certainly not across-the-board indication for aspirin, even after a heart attack. One of the things that physicians do is take a Hippocratic oath, and is to do no harm, and people think that aspirin doesn't cause harm, but again, aspirin can damage the liver, the kidneys, cause significant GI bleeding, potentially cause a stroke that is non-hemorrhagic to become hemorrhagic, to cause people to bleed excessively if they have trauma and they've been taking an aspirin prophylactically. So, little things like aspirin, which you think might be good for you, not without contraindications. Aspirin's also been shown to decrease endothelial reactivity, the very thing that we want to improve with greens, and that's through a prostacyclin inhibition type mechanism. But there's risk of hemorrhage, and particularly places like the brain that could cause things to be devastating. So you're in an accident, you're taking aspirin, the bleeding could be a lot worse. There was one study that looked at over 4,000 patients, and they were actually given 1,000 milligrams of aspirin versus placebo. They followed them for 25 months after their heart attack. There was no benefit as far as decrease in cardiovascular events, and there was actually increased mortality in women. There was a Swedish test that looked at over 2,000 patients that had chest discomfort, typical of angina, but they did not have stress tests or CATs to confirm it, but they gave them 75 milligrams of aspirin versus taking nothing. And at 50 months, there were 5 fewer heart attacks per 1,000 patient years, but certainly no effect on heart attacks, stroke, or death. There's actually been no randomized controlled trials on antiplatelet therapy versus placebo after stent placement, but we have put people on up to 3 blood thinners after stent, especially in the early days, because the biggest complication was clotting when you put a foreign object in a coronary artery. So people would be on 3 different ways to thin your blood, and resulted in a lot of bleeding, and it eventually got back down, And then it came down to aspirin and the Plavix type therapies that basically inhibit platelets. And, then we just said if you're a diabetic, then you should take it for the rest of your life. Maybe some people can stop at a year, but you should always take an aspirin. And we keep backing these things down, and we assume that there's good data to suggest that it's going to help. The reality of it is we don't have good randomized trials. Now, there are certainly people that are at very high risk that have very bad vascular disease, and there's not much in the way of alternative. Again, most of these people, we've not spoken one word about dietary intervention, just medical therapy, which, again, in the hospital setting, nobody talks about nutritional therapy. They just talk about medication therapy. And again, nobody wants to use nutrition because there's not been randomized trials about nutrition, even though there's not really been good randomized trials about the medication. And I am certainly confident that if you speak with your physician about a podcast with Dr. Dulaney saying that aspirin has no real benefits and maybe not even Plavix for the most part in most people, they will say that I am certifiably insane and there's nothing to that. Again, this is not a podcast that's giving out medical advice. I'm just stating the data, but I dare you to bring it up with your physicians, and I dare you to ask them to show you a randomized controlled trial stating the opposite. If a person is on these therapies, whether it be Plavix, clopidogrel, or Brilinta, or aspirin, and they have trauma, bleeding is awful. If you have to have surgery or procedure, we often have to hold it or take people off of this medications, and sometimes therapies or procedures are postponed. Not that maybe that's a good thing, they probably weren't indicated in the first place, but nevertheless, emergency surgeries pose a real increased risk of bleeding. Elective ones, require people coming off surgery, and they still continue to bleed even after being off for, a week or so. Bleeding complications are much higher. Most people that are on aspirin or Plavix for any period of time also have GI issues that require the addition of another medication to decrease the acid in the stomach, and that's where omeprazole and proton pump inhibitors really came into play because, again, the protocol would be aspirin, dual antiplatelet therapy, and then something to cover their stomach. And then turns out that the omeprazole-like medication, proton pump inhibitors, actually increase your risk of a heart attack. So to go back through, the aspirin might increase your risk of clotting. The medication to protect your stomach from the aspirin might increase your risk of having a heart attack. Not to mention osteoporosis and malabsorption of other good nutrients, such as B12. But you see, we keep covering our tracks as we go with some of these therapies. Sad to say that I participated in this protocol for quite some time until I was hit on the head with a Diet for a New America by John Robbins, and started to look in some of these things in great detail. So we're handed a lot of information as medical students and residents that we take verbatim. We take tests that the right answers are to start these therapies, and it's ingrained in us. And, how could something as benign as an aspirin cause so much harm? Yet it does. And it doesn't really stop there. Ibuprofen and those medications are used like water in some people. Anybody gets an ache or a pain, we don't assess why they're having the ache or a pain. They just pop one of these things to make that pain go away quickly. Well, it turns out that some of the biggest cash settlements for pharma have been associated with non-steroidal anti-inflammatory drugs and their increased risk of cardiomyopathy and heart attacks. Even simple drugs that are generic, like ibuprofen, over the counter, if taken, can cause almost immediate renal failure in some people that are susceptible, but certainly long-term use can worsen kidney function, increase risk of bleeding, tendon rupture, as well as, increasing risk of coronary artery disease or cardiomyopathy. It scares me to death when I hear people talking about taking ibuprofen during ultra races. They talk about and boast about popping them like candy to suppress their discomfort. It's kind of funny to me that people want to run an ultra race, yet they don't want to experience any discomfort, so it's okay to go ahead and take pain meds so you can get through something. Again, one of my wisest patients said that he didn't want to take pain medication because that was his body trying to tell him that something was amiss and that he should look into it. Very something. And I will repeat that. If you're having pain, why are you having pain? And what can be done to alter the reason why you're having pain as opposed to just masking the pain? So again, pain medications can be good and sometimes they're needed, but it's not going to hurt me. There's no risk to it. Is just not true. So everything should be individualized. We shouldn't have cookbook medicine for the masses. It should be, a particular patient and how might we help them. Certainly, it is better to give someone with terminal cancer that have bone mets some ibuprofen versus narcotics. Narcotics mask the pain, cause GI distress, addiction, and so forth. So, if you're weighing the odds, then maybe nonsteroidal anti-inflammatory drug would be in someone's best interest, especially for a short period of time. You can get away with things. But again, we shouldn't just take things like candy and assume that there's no side effects or downside to them. It kind of comes down to, let's assess the reason for your discomfort, not just mask it and go on. And that's what we do in our practice. We're very individual. Why is something happening? How can we fix the root cause as opposed to just masking it with a medication? If you want to improve your immunity over these next few winter months, since Punxsutawney, I think he saw a shadow, I don't know, but there's supposed to be more winter. Get outside when you can. Vitamin C, vitamin D, supplements if you're someplace where you have to wear a lot of layers when you go outside, but getting fresh air, going where there's trees, in a park, on a trail, is certainly better than being cooped up in a gym whenever you get a chance. And don't hide. There's a lot of evidence that small exposures to viruses and various microbes actually make your immune system more robust. So small exposures. Go outside, go to the grocery store. If you're afraid of the cart, get one that's outside. It's been sitting outside, it's going to be fine. But in and out of the grocery store, your risks are very, very low of having anything happen. Remember when people were afraid to touch the vegetables? There have been animal studies and puppy studies. Parvovirus in puppies is very lethal GI disorder that occurs, and parvovirus is almost everywhere in the environment, and it's rampant at dog parks, in places where there are lots of dogs, kennels. But there have been holistic vets that have actually done studies giving puppies 5 minutes of exposure, and not in a dog park, but in a neighborhood, in a low traffic area, just 5 minutes, and that helps to build their immune system over time. Same thing with children. Breastfeeding is the great immune enhancer and gives babies good immunity. And then small exposures, not, dousing them, unfortunately, in the daycare environment if you don't have to, because, again, that just results in infections, antibiotics, poor immune system, and the beat goes on. There is not enough vitamins and minerals in cereal to make a child healthy. They need exposure to fruit. They need outside exposure to fresh air and supplements and foods that contain vitamin D, as well as vitamin C. And so do adults. There are more adults with low vitamin D when we check than normal vitamin D levels. We know that people that have a normal vitamin D level, and I will say not a normal, but I'm going to say a vitamin D level of 50. So between 50 and 100, people do much better with respect to their immune system, less cancer, less complications from infection. So just because you're good and plant-based and you eat really good doesn't mean you won't get a virus, but you're more likely to do well if your immune system is good and you've had little bits of exposure. and your inflammation is under control. Omega-6 fatty acids are essential, but there's abundance of them. Omega-6 fatty acids found in seed oils, oils in general, and in most nuts, as well as animal products, increase thrombosis, increase clotting, increase inflammation. Omega-3s, such as chia, flax, hemp, beans, particularly pinto beans, greens, walnuts, decrease clotting and decrease inflammation. Not nearly as many omega-3s out there than omega-6s, so because they use the same enzyme pathway, you want to limit the seed oils in our food. And people say they don't use any, but it's in everything. So if you're eating processed food or you're going out and somebody else is preparing your food, you probably have no idea how much of that you're coming in contact with. Everybody jumps on the bandwagon, when there is an E. coli contamination of lettuce or some other produce, but the reality is that comes from most likely migrant workers or the way it's been processed, or if you eat out, again, not washing your hands. Soap and water cures all of that, prevents all of that from happening. But the risk is so low that it is no longer... we used to, when somebody was getting chemotherapy and their white cells were low and their immune function was being decreased, immunocompromised people, we'd say avoid fresh vegetables because of the potential contamination. The benefits of fresh vegetables and raw fruits and vegetables is much greater than the risk of contamination. Wash them in a sodium chloride type wash, rinse them. There are other washes you can do, but a little saltwater wash will take most of that off. I often get asked about the risk of Lp(a). Should I have my Lp(a) checked? I've talked about it before on the podcast, but now there's a medication that's in final phases of trials that are going to be released that potentially may decrease Lp(a), and so people that be another reason to test people, another reason to put people on medication. The mechanism is that it is a small interfering RNA blocker that blocks Lp(a) by decreasing the degradation of apolipoprotein a via messenger RNA. A lot of words, but RNA means DNA. Well, RNA is a transcription from your DNA. I can't think that this is a good thing as far as, again, I am not one for messing with Mother Nature, because when we start messing with our genetic sequencing or making of proteins by our genes, I think that there is fallout that we don't know is going to happen until it happens down the road. But there was a recent phase 2 trial looking at this drug, looking at oxidized phospholipids, looking at interleukin 6, which is an inflammatory protein, and high sensitivity CRP, which also is a marker of inflammation. The oxidized phospholipids are what that bind to Lp(a) and cause them to kind of turn on. It's like pulling the pin in the hand grenade that unleashes the ability for Lp(a) to cause vascular disease. One of the things we do with plant-based nutrition is decrease oxidation, which does not then turn on Lp(a), and you can have your hand grenade in the closet, but you don't pull the pin. Or you can, I guess, down the road, take one of these drugs that may decrease phospholipid oxidation, but it did nothing for interleukin 6 and did nothing for C-reactive protein. So, again, I'd rather do this nutritionally, eat healthy. Oxidized phospholipids are affected by our diet. So not eating animal products decreases oxidation, eating a lower protein diet, especially animal protein, decreases oxidation. Eating a low-fat diet decreases oxidation. Those are your big sources of oxidized potential, which lead to free radicals, which lead to inflammation, which lead to vascular disease. So, why change your mRNA when you can change your diet? Common sense. We need to get common sense back into the equation. We need to cook back in our own kitchen for the majority of time. There's nothing you can do to benefit your health and the health of your family more so than to cook your own food and to choose your own produce and to avoid animal products. There's nothing you can do better than getting outside and exercising and moving your body and keeping fit and keeping a normal body weight. It just comes down to how important is it really to you. A lot of people put it on the back burner until it's too late, and then we have to backpedal. Do it now, and you don't have to. If you want to find out more about our practice and how we can help you get things in check, go over your medications, do a side consultation, nutrition advice, strength training advice, go on over to drdulaney.com, DOCTORDULANEY, and check out our website. We have the availability for just $25 a month to have access to all our online material, including recipes and mobility videos and nutritional education videos and cooking demonstrations. And then we have more available through coaching, dietary coaching, and consultations by myself, strength training coaching. So if you're interested and you want to take control of your health, and health is number one, we would love to work with you because we would love to help you become the healthiest person that you can be. Thank you as always for listening, and I'll check in with you next week.